Good afternoon, everyone, and welcome to today's Public Health Ontario rounds on COVID-19 vaccine program surveillance. This is part one of a two-part series, and today's presentation will cover vaccine safety surveillance. And part two on June 3rd will be on monitoring vaccine impact and surveillance for special populations. So my name is Tara Harris, and I'm the Manager of Immunization at Public Health Ontario, and I'll be moderating today's session. Before we start the presentations, just a few housekeeping items. In your Zoom screen, you are able to customize your view, and you can do that from the right-hand corner of your screen. Please use the Q&A pod if you have questions during the session, and we'll save the questions until the end of the presentation. The chat pod has been disabled for the duration of the presentation. If you have any technical issues during the session, please email events@oahpp.ca. And finally, I'd like to state that as the moderator of the session, I don't have any potential conflicts of interest to declare. So turning our attention to our presentation today, it's my pleasure to introduce our speakers, Dr. Sarah Wilson, Whitley Meyer, and Dr. Matthew Muller. Sarah Wilson is a public health physician and the co-lead of the COVID-19 vaccine section of Public Health Ontario's incident management system structure for its pandemic response. Whitley Meyer is the team lead for the COVID-19 vaccine section of PHO's IMS. And prior to COVID-19, Whitley was a nurse consultant specializing in vaccine safety surveillance at Public Health Ontario. Matthew Muller is an infectious disease physician and medical director of infection prevention and control at St. Michael's Hospital. He's also the Ontario principal investigator for the Canadian National Vaccine Safety, or CANVAS, network. So with that, welcome to our speakers, and I'll turn it over to Sarah to start off the session.
Great, thanks very much, Tara, for that kind introduction. So Lydia, can you advance the slides for us, please? Okay, so none of the presenters have any disclosures to make or potential conflicts. And the outline for today, we'll talk about the COVID-19 vaccine program surveillance framework, and then we'll really focus the duration of the talk on vaccine safety surveillance, focused both on passive as well as active vaccine safety surveillance. And the next slide, please. And so our learning objectives are to describe the vaccine program surveillance framework, to understand the systems in place for COVID-19 vaccine safety surveillance, and then to describe recent findings from both active and passive surveillance systems monitoring COVID-19 safety in Ontario. And the next slide, please. Okay, great. So as we've covered in the objectives and the outline, we'll spend most of today's talk really focused on COVID-19 vaccine safety surveillance, but I thought it was important to situate the talk today on vaccine safety surveillance in the context of the broader COVID-19 vaccine program surveillance plan. So in terms of some background for this, I think everyone's well aware that the COVID-19 vaccines used in Ontario and Canada's programs have been rigorously studied. They've been rigorously studied in clinical trials that have involved tens of thousands of individuals. But as we all are aware, program implementation in the real world sometimes looks different than in clinical trials. We're using vaccines in individuals and populations who may have been excluded from those original clinical trials, for example, pregnant individuals or long-term care residents. And we're also deploying them in epidemiologic contexts that might differ from clinical trials, for example, in the context of variants of concern. And then, of course, there's also a policy and programmatic overlay to this as well. We've made decisions in Canada to delay the second dose to optimize and maximize the number of individuals protected from COVID-19 vaccine, the first dose, and that also needs to be monitored. So for all of these reasons, we need to really effectively monitor our program in real time, focused on a number of aspects: safety, effectiveness, and program impact. So let me tell you a little bit about the way we went about developing this plan. I had the pleasure of being the co-chair of the surveillance subgroup with Dr. Dirk Heyer. So this was a surveillance subgroup of the clinical guidance and surveillance work stream of the COVID-19 vaccine task force. And I'll have an upcoming slide to say thank you to all the members of that group who contributed to the plan. So in terms of how we approached this work, we first took stock of what are the existing programmatic features of vaccine safety surveillance and other vaccine surveillance systems in place separate from COVID-19 that would be used for the COVID-19 program. And then we reviewed plans and documents from other jurisdictions like Public Health England, the European Centre for Disease Control, and WHO, among others. And then we were also very fortunate that within our group, we also had some linkages to other groups discussing COVID-19 vaccine surveillance. Both myself and Dr. Jeff Kwong are members of the Vaccine Surveillance Reference Group of the Canadian Immunity Task Force. So if you go to the next slide, please, Lydia. So today in the introductory portion of today's talk, I'm going to walk through the main components of the COVID-19 surveillance framework. And any vaccine program surveillance plan starts first with what are the goals of the vaccine program. And so Ontario's COVID-19 vaccine program goals are to prevent death, to prevent illness, hospitalization, and ICU admission, and also to reduce transmission. And so we need to monitor the program to ensure that it's meeting those goals and to also think about how to, broadly look at program implementation so that those goals can be met. So again, at a very high level, the main components or the main pillars of the surveillance framework include the following: vaccine coverage, vaccine safety, program impact and vaccine effectiveness, viral characterization of cases with vaccine history, and then serosurveillance and public confidence. And so I'm going to spend just, a very brief whirlwind tour through these components, and then we'll narrow in on vaccine safety for this particular talk. So if you can advance to the next slide, please. So the first component, as I mentioned, is vaccine coverage, and this is obviously a foundational metric for any vaccine program. We need to first understand how are we doing in terms of administering vaccines, who is getting vaccinated, and who is not. So, we're looking at this over time by priority group, by age, by product, by dose number, et cetera. So I have a few figures just to illustrate this. This is a snapshot of the Public Health Agency of Canada COVID-19 vaccine dashboard. And Lydia, if you can advance to the next slide, I have some slides just demonstrating some figures from our PHO work looking at vaccine uptake over time for age on the left. And you can see some really nice representation of the differences in the slope of those curves, looking at different age groups. And then on the right, a figure that presents vaccine uptake by age in a slightly different way. So if you can advance to the next slide, please. The next slide, of course, today's talk is focused on vaccine safety. And so when we're talking about vaccine safety in the context of monitoring the COVID-19 vaccine program, we're referring to passive vaccine safety surveillance, which Whitley is going to provide an overview of today. So, receiving reports of adverse events, forms completed, sent into the public health system for further review and analysis. It also includes active vaccine safety surveillance. So Dr. Muller is going to speak about Canvas, but in general, the principle of active vaccine safety surveillance is that instead of waiting for passive reports to come in, one is actively looking for information on vaccine safety, whether that's in the form of collecting information from vaccine recipients, or in the case of IMPACT, which is an active vaccine safety surveillance network focused on pediatric hospitals, looking at medical records and charts to determine if there's any signals to make note of. And then finally, the third category is special studies. So special studies could include looking at vaccine safety in special populations like pregnant individuals, and Dr. Deshane Fell will be speaking about this topic later on in the week. But it can also involve more epidemiologic studies using health administrative data. Passive vaccine safety surveillance is really instrumental in identifying signals and hypotheses to explore further, but there is still a need for rigorous epidemiologic designs to really determine if the signal is truly an issue of sort of cause and effect. And the figure here on the slide is just a representation of a figure from the Public Health Agency of Canada vaccine safety dashboard that summarizes information on a weekly basis from the Canadian Adverse Event Following Immunization Surveillance System. So if you advance to the next slide, please. So the next slide is focused on vaccine program impact and vaccine effectiveness, the focus of 2 additional talks later on in the week. So vaccine program impact is, looking at trends over time in cases and the epidemiology of COVID-19 as vaccine uptake improves and increases over time, and also includes dimension like looking at clinical severity to see if clinical severity differs and is less among vaccinated versus unvaccinated cases. It also looks at vaccine effectiveness, so quantifying the impact of vaccination. What is the effectiveness of vaccines in preventing symptomatic infection or preventing hospitalization or death, and quantifying that for age groups and by vaccine product in rigorous epidemiologic designs that can control for a number of confounders. So Dr. Jeff Kwong will be speaking to Ontario VE estimates later on in the week. And if we go to the next slide just highlights the final 3 components, which are certainly worthy of their own talks as well. Viral characterization of cases with a vaccine history. So this highlights the work that our Public Health Ontario lab and other lab colleagues will be doing to better understand the virus among vaccinated cases, including whole genome sequencing. Serosurveillance, which is the study of cross-sectional antibody tests in a population to look at trends in population level immunity. And this work will also be something that is a feature of many vaccine preventable disease programs, and will be interesting to also look at trends from the perspective of the COVID-19 program. And then finally, last but certainly not least, public confidence. So this is really a crucial component to understand intention to be vaccinated, understanding knowledge, attitudes, beliefs, barriers, and enablers to really optimize our communication strategies and other program supports. So if you advance to the next slide, I'd just like to close by acknowledging the members of the surveillance subgroup and all of their important contributions and insights that they brought into the development of the plan, and to thank also the co-chair, Dr. Dirk Heyer, and really want to thank this group. And I'd like to turn it over now to, if we advance the slide, Lydia, turn it over to my colleague Whitley, who will be able to walk us through passive vaccine safety surveillance, and we'll move into the focus in vaccine safety for the remainder of the talk. So thank you. Over to you, Whitley.
Great, thanks, Sarah. So for the next portion of the presentation, I'm just going to outline the systems and activities that are in place for passive vaccine safety surveillance. Next slide, please. So to start off, I'll just review the definition and some key concepts of adverse events following immunization, reports of which we monitor through passive surveillance. So an AFI is any untoward medical occurrence that follows immunization. So it can be an unfavorable or unintended sign. It can be a laboratory finding, a symptom, or a disease. In terms of causality, AFIs can be caused by a vaccine, or they can occur by chance. So causal relationship does not need to be proven in order for an AFI to be reported. AFIs can include events that are unexpected as well as those that are expected. So an example of the latter would be an injection site reaction. So these are events that we know can occur after vaccination, but they may still be reportable if they meet certain criteria for severity. And lastly, it's important to note that there's a difference between AFIs and side effects. So side effects are those events which have been linked to vaccines by scientific studies. Next slide, please. So passive vaccine safety surveillance is a critical component of the overall vaccine safety monitoring. In Ontario, passive surveillance relies on healthcare providers, vaccine recipients, or their caregiver or parent to report AFIs to their local public health unit. In Ontario, healthcare provider reporting of AFIs is mandatory under the Health Protection and Promotion Act, and all other types of AFI reporting are voluntary. So once a report is received from the public health unit, they're responsible for investigating and assessing the report, as well as documenting this information in the provincial vaccine safety surveillance system called the Case and Contact Management System, or CCM. At Public Health Ontario, we conduct provincial vaccine safety surveillance using this data that's in CCM, and I'll get into Public Health Ontario's role a bit more later on. We at PHO also submit all reports of confirmed AFIs into the National Vaccine Safety Surveillance System, which is called CAFIS, and that's managed by the Public Health Agency of Canada. Next slide, please. So in terms of the goals of passive vaccine safety surveillance, clinical trials aren't large enough to reliably detect rare adverse events. So this is certainly an important goal of passive surveillance. As well, using passive surveillance, we can collect information on individuals' health history or some of their medical risk factors. And this information can enable us to detect risk factors or conditions that may promote certain adverse events. We also use passive surveillance to be able to identify signals or vaccine safety issues that may warrant further assessment or action. And some examples of this include adding information about certain adverse events to a product monograph for a vaccine, making changes to the counseling that takes place as part of the process for obtaining informed consent from a vaccine recipient, as well as holds or recalls on specific lots of vaccine or a specific product. Next slide. So this diagram here just depicts the flow of information for public health surveillance, the process for monitoring APHIS. So the arrows depict a flow of information, but it should be noted that oftentimes it's not only a one-way flow, and information is also shared back between these stakeholders. So the process starts on the left-hand side, as you mentioned, with an individual APHI report being submitted to a public health unit. The public health unit then investigates the report. They document this information in CCM. And part of the public health unit role is also to provide support and information to those reporting APHIs. So whether that be a healthcare provider or a recipient of a vaccine or their caregiver or parent. And this can include recommendations for a second dose if one is needed. In the next box on the right, so at Public Health Ontario, we conduct provincial surveillance, analyzing data that the PHUs or public health units enter into CCM. We also produce routine reports, and we conduct ad hoc analyses to support, support public health units that are investigating complex APHIs. Our colleagues at the Ministry of Health are responsible for immunization legislation and policy, as well as vaccine supply. And at the bottom there, as I mentioned, Public Health Agency of Canada is responsible for managing the National Vaccine Safety Database, or CAFIS. So reports of APHIs are submitted into CAFIS by public health authorities from all provinces and territories across the country, as well as some federal departments, so including, for example, the Department of National Defence, Indigenous Services Canada. And at FAC, they also analyze vaccine safety data to search for vaccine safety signals. And each week, as Sarah alluded to briefly, they publish a national report on COVID-19 APHIs that's available on their website. And lastly, with Health Canada, which is the regulator for vaccines in Canada. So Health Canada evaluates vaccines for their safety, efficacy, and quality, and authorizes a vaccine only once it's determined to be safe and effective. Health Canada also collects and reviews data that's submitted by the vaccine manufacturer. So manufacturers are required to report serious adverse events to Health Canada, and they do this through the Canada Vigilance Program. Next slide, please. So the slide here just takes a bit of a more in-depth look at Public Health Ontario's role in vaccine safety surveillance. So here at PHO, we have a multidisciplinary team of epidemiologists, nurse consultants, and public health physicians that work together to conduct daily monitoring of APHI reports, analyze the data, and also provide advice and support to public health units that are conducting APHI investigations, particularly those dealing with complex or challenging reports of APHIs. Each week we produce a report on COVID-19 APHIs that's available on our PHO's website, and I'll speak to that a bit later in further detail. Our team also participates in a National Vaccine Safety Working Group that's led by the Public Health Agency of Canada, and this group has representation from federal, provincial, and territorial immunization programs across the country, as well as other public health partners. Next slide, please. So as I mentioned briefly, we each week at PHO, we produce a report that summarizes COVID-19 APHIs in Ontario. And this report analyzes trends over time for APHIs that have been reported since mid-December, when the COVID-19 vaccine program began here in Ontario. This report is updated each week on Wednesdays and it's posted on our website. In the report, we break down APHIs by adverse event type, as well as by age and sex of the vaccine recipient. We also break down reports by the vaccine product. There's also a breakdown of reports of serious and non-serious APHIs, so the latter being those that require hospital admission for the adverse event, or those that are also reports of death. In the report, we also describe medically important events using the World Health Organization criteria. And these type of events may require intervention to prevent them from becoming what we describe as a serious AFI. So some examples of these events are events managed as anaphylaxis, Guillain-Barré syndrome or GBS, or encephalitis and encephalopathy. We also describe in our report adverse events of special interest. So these are events that have been identified by international health authorities, including Public Health Agency of Canada, the World Health Organization, as well as the Brighton Collaboration, as events of special interest for COVID-19 vaccine safety surveillance. So some examples of these include vaccine-associated enhanced disease, multi-inflammatory syndrome in children and adults, and thrombosis with thrombocytopenia, and vaccine-induced immune thrombotic thrombocytopenia, so TTS or VIT. Next slide, please. So the slide here just is a short summary of our most recent vaccine safety report that was published online last week. So as of May 22nd in Ontario, there have been a total of 3,569 confirmed AFIs reported in the provincial surveillance system. And this is following over 8 million doses of vaccine administered, which gives us a reporting rate of 44.2 per 100,000 doses administered. And that represents 0.04 of all doses administered of COVID-19 vaccine. So the vast majority of AFIs that have been reported to date, just over 96%, have been classified as non-serious. Next slide, please. So this slide here outlines the top 10 most commonly reported adverse event types as of May 22nd, the top 2 of which are allergic skin reactions and local or injection site reactions, which combined make up over 50% of AFI reports received. The third category there listed as other severe or unusual events. And this category includes events that do not meet the criteria, the predefined criteria outlined in Appendix B, or the reporting guidance document for public health units. So some examples of events that have been reported in this category include things like prolonged headaches or fatigue, chest pain is another example. It should be noted that an individual AFI report can include more than one adverse event. So the sum of all the adverse event specific counts may not equal the total amount of AFIs reports submitted. Next slide, please. So in addition to producing a weekly report on all AFIs, Public Health Ontario also conducts in-depth analysis on specific adverse events of interest, as well as signal investigation, or looking into a potential vaccine safety issue. So one example is a report that we published back in March. It's available on our website, summarizing reports of anaphylaxis following COVID-19 vaccine. So this report was initiated based on an observed increase in reports of anaphylaxis compared to the usual AFI reporting rate of anaphylaxis. And what we were able to find is that the report did validate that there was an increase in AFI reports compared to the usual rate, although it was still a rare adverse event. Some other examples of investigations or analysis that our team has done include responding to lot-specific questions. So for example, if we hear of reports of a cluster of adverse events that are associated with a particular lot of vaccine, also looking into adverse events associated with a specific vaccine product. So one example of that is the delayed injection site reactions that have been observed following Moderna vaccine. And lastly, currently at PHO, we're conducting enhanced surveillance on thrombosis with thrombocytopenia syndrome, or TTS, and vaccine-induced immune thrombotic thrombocytopenia, or VIT. So public health units have been asked to notify Public Health Ontario of any cases that they're monitoring of these 2 events. And a summary of these reports are included in Public Health Ontario's weekly AFI summary that's published online. As well, the Public Health Agency also includes a summary of these events in their national report that's available weekly. And our team here at PHO is also planning on doing an enhanced EPI summary on these events in the coming weeks. Our team has also developed some resources for public health units to assist them with investigating and reporting these adverse events. Next slide, please. So the slide here just outlines an example of vaccine safety surveillance in action, specifically with regards to TTS and VIT. So as many of you will be aware, reports of this adverse event, which involves blood clots with low platelets or thrombocytopenia. These reports following AstraZeneca vaccine started in March in Europe. And then following this international monitoring, this adverse event began. So this included raising awareness among healthcare providers to look out for this event and report it to local public health, as well as guidance to providers on how to manage this adverse event in these cases, and information for vaccine recipients on what signs and symptoms they should be aware of following vaccine administration. In April, Public Health Ontario issued an enhanced surveillance directive, which I spoke to briefly before, to assist in expedited reporting of these events to PHO and also to Public Health Agency of Canada. Over the next little while, case finding definitions were developed for this adverse event by the Brighton Collaboration, which is a global expert vaccine safety network, as well as the Public Health Agency of Canada. And these case definitions were used to assist jurisdictions in identifying and reporting these cases. There's been ongoing sharing of information related to these events, both nationally and internationally, with all vaccine safety surveillance partners. In May, due to an increase in reports of TTS and VID observed, and as well as an increase in reliable supply of mRNA vaccines here in Ontario and a downward trend of COVID-19 cases, the Ontario government made the decision to pause on first dose administration of AstraZeneca vaccine. And in Ontario, and as well as nationally and internationally, we're continuing to actively monitor the situation of related to these events. Next slide, please. So the slide here just outlines what's currently being used as the national case definition for TTS and VID. This was developed by the Public Health Agency of Canada and adapted from the interim Brighton Collaboration case definition. So TTS is a condition that's characterized by the presence of new onset thrombocytopenia, as well as venous or arterial thrombosis, with no known recent exposure to heparin. The Brighton Collaboration case definition does include a further subclassification for exposure to heparin, so those cases can be further stratified based on heparin exposure. And cases of TTS are then further subtyped based on results of laboratory testing for platelet factor 4 antibodies, or anti-PF4. So basically, if the anti-PF4 result is positive, then these cases are considered to be a confirmed case of VID. Next slide, please. So in terms of what we're seeing in Ontario for this adverse event, as of May 22nd, there's been a total of 16 reports of TTS in Ontario after first dose of AstraZeneca or Covishield vaccine, and 13 of these are VID. For TTS, this represents a reporting rate of 2 cases per 100,000 first doses administered, or approximately 1 in 50,000. And for VID, this represents 1.6 per 100,000 first doses administered, or approximately 1 in 61,000. It should be noted that these reporting rates are based on numbers of doses of AstraZeneca or Covishield administered in Ontario as of May 1st, 2021, so denominator of around 790,000. So the state was used to account for the lag period between the vaccination and subsequent symptom onset, which can typically be anywhere between 4 and 28 days. It also accounts for the lag in the time it takes for clinical recognition of this syndrome, as well as reports making their way into the vaccine safety surveillance system. So to date in Ontario, there has been 1 death recorded in CCM in an individual with VID, but however, the cause of death at this time has not yet been determined. On the reporting rate for TTS and VID, the Ontario reporting rate for TTS and VID is similar to the national estimate for VID following Covishield, which at this time is currently 1 in 55,000. And this is an evolving situation with estimates of the rate of TTS and VID and reporting rates for this adverse event changing quite rapidly. So this slide here just outlines some resources on vaccine safety and APHI reporting that are available from Public Health Ontario, all available on our COVID-19 vaccine webpage or our vaccine safety webpage. Next slide, please. And finally, I'd just like to acknowledge the tremendous efforts of our colleagues here at Public Health Ontario working in COVID-19 immunization program surveillance. And I'll turn it over to Dr. Muller to talk about vaccine safety, active vaccine safety surveillance.
Terrific. Thanks very much. Thanks very much, Whitley. So I'm going to be talking about the Canadian National Vaccine Safety Network, or CANVAS, which is performing a active safety surveillance in Ontario and in other provinces, which I'll get to. So we could go to the next slide, please. So Canvas has actually done this for a number of years, and I'll point out we're working very closely with PHO, but this is not a part of PHO. We're funded through the Public Health Agency of Canada and CIHR. We've been doing this since 2009 with a focus on seasonal flu vaccines, initially pandemic flu vaccine, and then occasionally other new vaccines such as the meningococcal B vaccine in 2014. And there's a couple publications referenced there, but there's a number of publications that Canvas has put out over the years relating to surveillance that's been done for these vaccines. As mentioned, I think we're doing active surveillance, and Whitley was talking about the passive surveillance network. And I think it's important just to pause for a second and reflect on the differences, because I think these are very complementary systems. So one of the strengths of the passive surveillance you've heard about is that it's covering all of Ontario. So anybody that has a potential APHE that meets the criteria for reporting, as was mentioned earlier, their physician or the family member or themselves or the person themselves could report their APHE, and it would be followed up as part of that passive system. Active surveillance is one of the disadvantages is it's more labor intensive, but we enroll people into Canvas and then we follow them forward, even though they haven't had any type of adverse event. We're following everybody that joins us before we know if they're going to have any kind of side effect, APHE, or reaction after vaccination. And this means that we eliminate some of the biases with the passive surveillance. So with passive surveillance, for example, if a physician knows that a side effect might be linked to the vaccine, they may be more likely to report it. Whereas if it's a new side effect or APHE that people don't know about, it may be less likely that they report it. Whereas we're really asking everybody participating to describe any change in their health, and I'll get into that in a bit more detail as we go forwards. So it eliminates that type of bias. And you could see, for example, that if you get a vaccine and you have an anaphylactic reaction 12 minutes after you're vaccinated, it will be obvious to everybody, most likely, that this would be an event that should be reported. If you have a deep venous thrombosis in your leg 28 days after vaccination, before we knew about VIT, it may or may not be clear to the treating physician and certainly not to the public that this had anything to do with vaccination. We now know that it might because of this syndrome that's been described. And if you had, say, chest pain 4 months after vaccination, there's a good chance that wouldn't be reported, as most people might not assume that that could have anything to do with vaccination. And at this point, there's no evidence that it would have anything to do with vaccination, but active surveillance can help us identify whether there's something unexpected or unknown that hasn't been reported before. So we'll come back to that in a little bit. The other thing that's unique about Canvas is we have a control group. So we have people that haven't been vaccinated participating in Canvas, which also allows us to monitor the frequency of any of these symptoms or syndromes in a population of people that were not vaccinated, which ultimately will tell us, is the symptom more common in people that are vaccinated compared to not vaccinated. So if you follow enough people, some of them will have chest pain 4 months after they've been vaccinated, but other people will have chest pain say 4 months after you start following them, even though they weren't vaccinated, just because this is a common symptom in elderly patients, for example. And so if we see a certain rate of chest pain in people that are vaccinated, but just as much chest pain occurs in controls, we're more confident that this is not really an effect of the vaccine, but just something that we might be expecting to find. So when we were doing this surveillance focused on seasonal flu vaccines, over the years, Canvas has been growing, and we actually were quite pleased over the last couple of years to be able to recruit over 50,000 people to participate in an active fashion in Canvas. And we were well positioned then to adapt Canvas to active surveillance for the COVID vaccines. So we could go to the next slide, please. So a bit of background that's already been covered to some extent, but really just to emphasize is that the COVID pandemic has been a unique challenge to healthcare and public health across the world. And really the development of 4 Health Canada approved vaccines that are all demonstrated to be highly effective is really a remarkable accomplishment in the time frame that this pandemic has occurred. And they've all been proven effective in phase 3 trials that often involve tens of thousands of people to demonstrate their efficacy and safety. But to really beat back this pandemic, we need to achieve herd immunity through vaccination. And the exact number of people that need to be vaccinated is not entirely known, but it's somewhere in the range of, we'd like to see 70 to 90% of the population vaccinated, ideally, of course, 100%, to really limit the opportunity for COVID to transmit within the public and to end the pandemic. But to do that, and this was also mentioned before, we need to build public trust. And so it's critically important that people understand that these forms of passive and active surveillance are ongoing, and that we will detect any side effects or adverse events associated with these vaccines, and we'll share this information with the public as it becomes available. So I think that just to emphasize why it's important to have different and complementary systems of surveillance. So we can go to the next slide. So the objectives specific to Canvas were to identify the incidence of what we call health events associated with COVID-19 vaccination, and to stratify that by vaccines, or are there different events associated with the different vaccines, as well as by demographics such as age and gender and health-related factors. In particular, one thing we're doing is studying populations that weren't included in the phase 3 trials. So for example, pregnant women were excluded from those trials, but not from Canvas. And so we'll have an opportunity to measure safety in pregnant or breastfeeding women, in people with immunocompromising conditions, in people with autoimmune diseases, and in people who have had prior COVID who may not have been included or may have been underrepresented in those phase 3 trials. We can also identify the incidence of health events that are severe. And we define that as severe enough to interrupt your daily activities, prevent you from going to work or attending school, and the severest events that may require a medical assessment. And within that, there's a subgroup of people that are actually require an ED visit or admitted to hospital. So we can look at severity through a number of different perspectives. And then again, as mentioned before, we can determine if the events are more common in people that were vaccinated compared to our control population. And that publication there at the bottom will be our protocol for Canvas is in press and will come out in BMJ Open, so you can read further details of how this happens. Again, to be specific about the term used, I talk about health events as opposed to AFI because we include a control group. So we define a health event as any change or worsening of a person's health while we're monitoring them. And that would include people that haven't been vaccinated. So an AFI is an adverse event following immunization. And since we have a group that aren't immunized, we tend to refer to these things as health events. Next slide, please. So again, we're recruiting in 7 different provinces and territories that account for 75% of the Canadian population. The exact way that we recruit varies by province, but the provinces that have been most effective at doing this have some form of automated mechanism, which is what we have in Ontario. And so, we're very grateful for our collaboration through COVAX, PHO, and the ministry to ensure that our surveillance system is kind of baked into the vaccination process in Ontario. So for those of you that have been vaccinated, you may recall, and hopefully you were asked a question, which is, do you consent or do you agree to receive emails from COVAX about possible research studies? And one of those studies is our active surveillance system. And so if you say yes to that, you should have received an email within 24 hours asking you if you're interested in coming to the Canvas COVID website to find out more information about Canvas, to consent and to enroll in Canvas. And that's the link there. So www.canvas-covid.ca. And then once you go to the website, you can enroll. And our goal is to enroll about 240,000 people per vaccine product. So 240,000 people receiving Pfizer, 240,000 receiving AstraZeneca, et cetera. Next slide, please. Our control, the main criteria to be a control, of course, is that you're unvaccinated. You can be intending to be vaccinated. So you can change from a control to a vaccinee, that's no problem. But if you're already vaccinated, you can't participate as a control. And we've been recruiting controls from our prior Canvas participants, as well as participants from other vaccine studies who agreed to be contacted for future research. So they were contacted earlier in the pandemic to participate as controls. And then we've had some media attention related to Canvas. And so we're always asking people, so including anyone on the call, share this with anyone who's unvaccinated. You just go to the website and you can click on the website and enroll as a control if you're unvaccinated. So next slide, please. So this is what you see when you go to the website. There's some categories at the top. You can see there's a results section, but you can click enroll here. And then there's a button if you've been vaccinated, And really that only applies in Ontario if you've received that email, but we want to make sure that you enroll within the first 8 days of vaccination. But if you are within 8 days and for some reason missed the email, you could still go to the website and click enroll, or you can enroll if you haven't had the vaccine. And of course, you can do that at any time if you're unvaccinated. So next slide, please. So in terms of data collection, the people that have been vaccinated will receive a survey that will collect information about these APHE or health events. And the surveys are done 1 week after each dose of the vaccine that you receive, and then again 6 months after all your doses are complete. So we do get some long-term follow-up of people for health events. And again, if you report a health event, if it's severe enough that you require a medical visit, whether it's to ED, family physician, walk-in clinic, and so forth, that triggers us to actually phone you, and we collect further details of your event. Finally, there is some flexibility built into Canvas, and so we can trigger phone interviews to collect more detailed information if there's concern about a particular potential APHE that's reported elsewhere. So for example, if there was concern about Bell's palsy related to the vaccines, we can turn this on so people that start reporting facial paralysis would receive a phone call, for example. We could also have the potential to add additional surveys if a very particular health event is identified that we need further details on. And then for the controls, depending whether they're either a retrospective or proactive control, if you're a prospective control, which was mostly early in the pandemic, you would get a survey at 1 week, 1 month, and 6 months, mimicking what would happen in people that are vaccinated. The vaccine campaign, fortunately, has rolled out so quickly that we've reverted mostly to retrospective controls, because many controls who are unvaccinated today may be vaccinated, next week. So what we do with this group is essentially they answer all 3 surveys at once. So it asks about health events in the last week, health events in the last month, and health events in the last 6 months, in the same way that we ask the people that are vaccinated, but all in one survey. So we could go to the next slide, please. So in Canvas, health events are those events that follow vaccination within a defined period. But again, there's no assumption that it was caused or not caused by the vaccine. And in fact, the vast majority of these are likely not directly related to the vaccine. And our definition of a severe event is one that involves missing work or school, interrupting daily activities, or the need for medical assessment. And again, we're comparing these with controls to determine whether the rate of these events is higher in our vaccinated population compared to our control population. We do feed into the passive surveillance system. So when we have a severe health event that's recorded in somebody that's been vaccinated, if it meets the criteria for reporting to public health in Ontario, we forward those reports on to the local public health unit, who can conduct their normal review of the event and then forward it on to PHO if it meets their criteria as a significant event. Okay, next slide, please. So just show you some of the results, and again, let you know that you can come back to the website over time. We do post results on the website, and as there's publications and further information that comes out through Canvas, it will end up on the website. Most of the results I'm going to present to you are really about our recruitment so far, and I'll come to that in a moment. But what this slide shows here is the gray bars are everybody that enrolled in Canvas. The black bars are over time. The black bars are those that completed their survey. So you can see almost everyone who's enrolling sticks with us and completes the survey, which is terrific. And then the tiny red bars are people completing their second dose survey. And this is one of the reasons I don't have too many results for you today, because we're really waiting to start to see the number of second doses increasing. That gives us a bit of longer term follow-up to really look at these health events. So next slide, please. But to give you a snapshot about the kind of questions we're going to be able to answer, we already have over 260,000 people enrolled just in Ontario. We have 8,000 controls, again, just in Ontario. This includes a large number of immunocompromised individuals, a large number of people that are pregnant or breastfeeding, and a large number of people that have had prior COVID. So we will be able to answer some of the questions that have come up as hypotheses, such as, are APHE more common if you are vaccinated after having had COVID? are they more common in people with autoimmune diseases and so forth? We can answer some of those questions and also provide additional, there's no evidence at the current time that there's any safety signal or issue with pregnancy, for example, but this should provide some added reassurance because we'll have follow-up up to 6 months on thousands of pregnant women across Canada who have chosen to be vaccinated. Next slide, please. Again, the people that enroll in Canvas are just a snapshot of who's getting vaccinated in Ontario and beyond. And so just like the vaccine campaign so far in Ontario has administered the most doses of Pfizer, the most people in Canvas have received Pfizer, but we do have significant numbers of people that have received the AstraZeneca vaccine and the Moderna vaccine, which also will allow us to look at the AFI by different vaccine product. Next slide, please. And this is just to show that the system is working. And so this is when people complete their survey. We really want people to do it right on day 8 after they're vaccinated so that they can really remember any AFI that they've had over the past week. And the graph just shows that people are doing a great job of completing the surveys on time. So there's a few stragglers out to about 2 weeks, but most people are doing this when they first get the survey. Next slide. So this is what I presented there was Ontario data. So this is just some summary data from across the 7 provinces and territories that are reporting. So the slides are already out of date because the numbers keep going up. But from a few days ago, we had over 900,000 people enrolled in Canvas across Canada. Again, you can see that a lot of people have done the dose 1. But because the dose 2 has been delayed across Canada as a strategy to get more people there dose 1, we're waiting for the dose 2 numbers to rise, but I anticipate that they're going to start rising quite rapidly and we'll have more data in the weeks to come. So about over 500,000 completed surveys for dose 1, but only about 4,000 for dose 2. As expected, the most common thing that we see is injection site pain, swelling, or redness in about half of people. Mostly that's likely just the mild pain that was reported in the phase 3 trials and goes away quickly. So this is an anticipated finding, but there will be an opportunity to compare vaccines for this as we go forward. Next slide. In terms of other health events, you can see that this occurs in about 9% of people in Canvas. And again, this is defined differently than in the passive surveillance, so it shouldn't be a surprise that these numbers are different and no evidence necessarily that these are related directly to the vaccine. We've asked people to report any symptom that occurs over the week following vaccination. We see a slightly higher rate after the second dose, but it's probably too early to draw a firm conclusion there again based on the small number of doses administered. And similarly, there's a smaller group of people where these events are severe enough that it impedes their daily activity. But a reminder that that could mean that they had anaphylaxis and ended up in hospital, but far more commonly, these are people that feel tired and have headache and maybe miss a day of work. And so when we actually look at the number of people hospitalized, for example, it's vanishingly small. So this is a handful of people across our 900,000 people vaccinated. So next slide, please. And the most frequent health events that are reported are also not surprising up to this point. So fever, fatigue, systemic symptoms in about 4% and 2% with GI symptoms. Next slide. So in conclusion, Canvas is providing active screening that gives us rapid data on vaccine safety and supports the passive screening or passive surveillance done by public health. So these are complementary systems. I think the Canadian investment in Canvas flu surveillance is paying off because we were able to scale this up rapidly to deal with COVID, and I think emphasizes the need to continue with vaccine surveillance even when the pandemic is winding down. It will provide some data on understudied groups such as pregnant women who were excluded from the phase 3 trials. We also have 6 months of follow-up, so actually more than 6 months because it's 6 months from their last dose. So we may end up with 8 or more months of follow-up on these vaccines to ensure that their safety in the long haul. And as I said, we don't have a lot of data yet in terms of the dose 2 surveys, which will actually give us several months of AFI data once that starts rolling in, because we ask about adverse events going back to their first dose on the second dose survey. But stay tuned, we'll have those results soon. And next slide. And so I just want to acknowledge that in particular, working with Dr. Wilson and her team at PHO and through COVAX and the ministry has really been critical. We couldn't recruit all these people to do this manually with, say, asking people to participate in person. I could never allow us to recruit almost 1 million people across Canada. So our collaboration with PHO and COVAX has been absolutely essential. So thanks for that. And I'll turn it back to Tara now for the question and answer.
Okay. Thank you so much, Matthew, and to Sarah and Whitley as well for all of your excellent presentations, and happy to move to the Q&A portion of our session. So you can use the question and answer pod at the bottom of your screen to enter your questions. And we have a few questions in there already. So I'll just move to that. And maybe start with there were a couple of Canvas questions that came in. So for Matthew, one of the questions was, how is the Canvas sampling impacted if we know that not everyone has been asked about vaccine research when vaccinated? And maybe I'll just sort of combo that with another question that someone had noted that they hadn't been asked, and so are all sites participating?
Yeah.
So I'll turn that over to you.
Sure. So I think there's been some fluctuation, and there was a graph, we don't need to go back to it, but we had good enrollment and then it dropped and then it picked up again. But we're consistently kind of getting 10 to 15% of people vaccinated enrolled. And so I think we have a very representative sample, and it is across all vaccination sites. So it's not just at the large clinics, for example. For various reasons, I think people may forget to ask the question or not ask the question. Again, if you happen to know about Canvas, you can still enroll. But despite all that, I think really we're very pleased with the recruitment that we've had, and we think it's quite representative of different age groups, different vaccines, and different sites.
Great. Thank you. Maybe just picking up on what you said at the very end there about age groups, there was one question here, whether Canvas was following just adults, or is it including the youth ages that have just been added for eligibility?
Sure. So the quick answer is we'd like to include 12 and up, but we didn't anticipate that the rollout would get down to that age group before September. So we're actually in the process of getting research ethics approval to enroll that group, but we'll hopefully have that soon and begin enrolling.
Thank you. Okay, let's go there's some questions on the passive surveillance side of things. So a question for Whitley or Sarah to elaborate on the difference between a side effect and an AFI. I know you touched on that on your presentation, and just to sort of further expand on the concept of those two types of events. The differences,
sure, yeah.
I guess.
So so an adverse event following immunization, as we mentioned, there's no sort of causality piece there. It may or may not be caused by the vaccine, where side effects are events that have been studied and have been linked to the vaccine through scientific studies. So that's sort of the discrepancy there. Sarah, I don't know if you had anything to add to that, but.
Maybe the only other thing I'll add to that is just, I think in terms of the types of health events that Matthew was describing in terms of fever, fatigue, we wouldn't expect that those would be reported as adverse events. And in fact, if we had reports for everyone who's sort of feeling a bit off or feeling a bit tired, I think it would really overwhelm the passive vaccine safety surveillance system. We're really looking for, certainly we do receive reports of fever, but it's sort of fever in combination with other events or something that would be very, very unexpected. So I think that's the other element too, that, we do expect some reactogenicity, and we wouldn't expect that all of those would be reported as AFIs.
Okay. Thank you, Sarah and Whitley. A couple questions on VIT. So the first question on the slide outlining the proportion of AFI types, I think that was the one Whitley covered with the top 10 types of AFIs. Where would events of VIT be included?
So that slide there outlined the top 10 reports of AFIs. And so the 10th most commonly reported AFIs on that slide was events managed as anaphylaxis. And I'm just looking here, it's over 100, probably close to 150 reports. And to date, as I mentioned, for VIT, we've had 16 cases of TTS reported. I'm just going back to the numbers here. Yeah, 16 cases of TTS and 13 reports of VIT. So, certainly very low in terms of looking at, that graphic was just looking at the top 10. So it's certainly not among the most commonly reported adverse events. However, as I said, we're still continuing to monitor these events and receiving reports of these events. So those numbers are changing rapidly. However, certainly not among the most common events that we're seeing.
Thanks. Another question related to VIT. Great presentation was one of the comments. Do you know the rate of VIT, what the rate of VIT is with the second dose of AstraZeneca, either from Canadian or international data? I wonder if maybe Sarah could take that one.
Yeah, happy to answer that question. So I'm not aware of any report of VIT that has followed a second dose administration in Canada. So that, which probably relates to ongoing decision making among provinces and territories. So we don't have any Canadian data, but I think there is very high quality information from the United Kingdom in terms of their passive vaccine safety surveillance system. They make their data available every week on Thursdays. And so they break down their reports of VIT in relation to first dose and second dose. And so it has been evolving over time. And so originally the estimates, even just a couple of weeks ago, were in the range of 1 per 1 million doses. And then in the last 2 weeks, so last Thursday and then the week before that, they were in the range of 1 in 600,000, and last week 1 in 625,000. So the rate does appear to be quite a bit lower than the rate associated with first dose of AstraZeneca, but I think it's also fair to say that the information in this area is very, very much evolving, and that there is likely to be, some fluctuations in the reporting rate over the weeks to come as more second doses are administered in the United Kingdom, although they certainly are using an existing robust surveillance system that's capturing also information on their first doses.
Thanks, Sarah. Okay, couple Canvas questions. We'll turn over to Matthew. So the first question, or the first question I have is, the question is, why is Canvas only taking Ontario participants following their first dose?
Yep. So if you've had your first dose and you didn't enroll in Canvas, some people have asked, could we participate starting with the second dose? Really, we've been fortunate. One of the drawbacks of active surveillance is it is labor intensive, because if you're following anaphylaxis, you have a handful of cases to follow. But if you're following everybody, right, we have our almost a million people in Canvas. So we actually can't really take every single person who's been vaccinated into our active surveillance, just in terms of the phone calls and so forth. So we have decided to limit it to people captured within 8 days of the first dose, to make sure we have complete information on them and they're able to do all 3 surveys. So unfortunately, if you didn't get a chance to enroll within the first 8 days of the first dose, then we're not really taking people in. And in fact, because our goal is about 250,000 people per vaccine product, we're likely to stop enrolling people in certain age groups who've received Pfizer, because we've reached our target. We're trying to make sure we also have representation by age. So in some older age groups with Pfizer, we're already at our target, and we may stop recruiting. You can always what happens is you'll go to the website and they'll say, thanks so much for thinking of us, but we don't need to enroll anybody else. And so the goal here is to have enough information that we can be confident that we're not missing any AFI, but to make sure we have the resources to study the vaccine products that we have less data on, like the Moderna and the AstraZeneca, for example, or anything new that comes along if the Janssen vaccine starts being used and so forth.
Great. Thank you, Matthew. I think maybe this is just one quick question of clarification on the Canvas data that you presented. Does the AstraZeneca data include Covishield?
Yes, it does. Yeah, our plan is to include all Health Canada approved vaccines. So even if there's a new vaccine that comes down the line while we're still running the program, we would include it as well.
Okay, great. Thank you. A lot of really great questions here. So might try tackling at least one more. Can the panel comment on response to vaccination errors? So observing that some patients have experienced bruising or incorrect placement of the vaccine, and clarifying if this would be reported through usual AFI reporting.
Yeah,
so maybe for Whitley or Sarah.
Sure, I can start off, and Sarah, if you have anything to add, feel free to jump in. So in the provincial surveillance system in CCM, we do capture reports of immunization errors. So if an error does occur associated with an AFI, then it can be reported. So for example, if there's a landmarking error, if someone received the vaccine in the wrong, at the wrong site, those things are reportable. But that's only if there is an AFI that's been reported in association association with the immunization error. If there's an immunization error that's not reported with an APHE, so this person, there was an immunization error, but they didn't subsequently have an APHE, then those are reported through another database, and right now I'm forgetting the name, it's escaping me. I don't know if anyone else knows the name off the top of your head, but essentially the reports of immunization errors associated with APHEs are captured in CCM, and those without, those errors without APHEs are captured in another database.
Kara, do you know the name of that system? I think the thing to
Oh,
highlight for
yeah.
for the participants is that it is a voluntary system. It doesn't, so in terms of the system, and we can maybe send it out to the attendees with the evaluation or some other efficient mechanism, the website for reporting. But I think it's important to note that it's voluntary and it's separate from the public health system. So it's not coming back to PHO or to the ministry, and it captures a number of different errors, including medication errors. So it's not specific to immunization, but that is sort of a pathway if people choose to report those events that, as Whitley has said, are not associated with an adverse event. Although it looks like from the comments or the question that the attendee is quite interested in reporting those that might be associated with an adverse event.
I think it's the Canadian Medication Incident Reporting System.
Thank you.
I know it's in a number of our materials. Okay, I think we've come to time. So thank you all for your questions. There were a lot of questions, and if you've identified yourself, we can take a look at responding to those questions that have been posed in the chat pod. But otherwise we'll wrap up today's PHO round session. I just really want to thank sincerely Sarah, Whitley, and Matthew again for your presentations, and to all of you for joining our session today. And it's great to see such great participation. So just a note that you can access past PHO rounds and presentations and see upcoming sessions by visiting the PHO website. And lastly, you can expect to receive a brief and anonymous PHO rounds evaluation survey for today's session shortly. So please do try to complete that to help us improve our programming. So thank you again, and I hope you all have a wonderful afternoon.